Thank you, Wei. Thank you, Palma, for the invitation. And I found this interesting article about the burden, global burden of aortic aneurysm, and for the sake of the World Federation, I also found this data of age standardized rate of deaths of aortic aneurysm, and I was surprised that regionally the highest age standardized rate of death of aortic aneurysm was found in tropical Latin America, and I didn't know about that. So it's an important subject for for the AUCVA and for our Latin American countries. So. And this is a map showing in the reddish colors the importance. And we know that aortic arch aneurysms treatment represent the last frontier in search of endovascular solutions. And we're dealing with that. This is from a former resident of us that in a custom-made prosthetic device for the left subclavian artery and a scallop for the nominate artery, we could do a total endovascular solution. And also this interesting case with a pseudoaneurysm after a pulmonary transplant that cardiac surgeons really don't know exactly what to do to be a re-sternotomy in a transplant patient. And we could do just this with this low-profile prosthetic device from the subclavian artery and with guided by echo Doppler, transesophageal Doppler, we could find a very elegant solution. But that's not usual. And so we are going to talk about the hybrid solutions. The object of this presentation is the hybrid solution for aortic arch aneurysm. This is our statistics from 2011 to 2022. And from 630 aneurysms, we have 2%, 53 patients with involvement of the aortic arch. These are the zones from zone 0 to 1 and 2. And this kind of patients that we're talking about. And for this patient, we did a bifurcate dacron graft from the ascending aorta to both carotids, and this is the solution after the implantation of a Gore device. At that time, Gore provided these kind of prostheses for the public system. Now they don't provide it anymore. It's very expensive. They are very protective about their profit, I think. And this is another patient. We modified that technique, and this patient we found contact with other specialists. This was an information from the people from Milano, Dr. Chiesa, Dr. Melisano, that it was better to construct a 8 dacron graft in that configuration, and this is the ascending aorta, and this wrapping with a metallic marker, so it make easy the endovascular solution afterwards. And this is the pre and post-operative solution, showing the graft in place and the metallic mark after the endovascular. And we have several situations, like when there is a mammary to coronary artery bypass patent, and then it's imperative to do the vascularization of the left carotid. This is this case, for instance, and we use very often, especially for this. It was a young, no, not young. It was a small Japanese lady, and so we had to provide a workstation for the iliac artery and for the subclavian. It's much easier to do the subclavian access below the clavicle and then to do the embolization of the origin of the left subclavian artery, because surgical exposure just near the vertebral artery is not always easy, and sometimes you do the ligation proximal to the vertebral artery. And I had some complications with the use of prosthetic material for the carotid bypass. So I'm very keen on using saphenous vein. Alberto, this is another use for the saphenous vein in the cardiac surgeons don't think that it's possible to use the saphenous vein in this configuration, but it's just beautiful. And this is another case of type B aortic dissection completed after the treatment with a proximal endograft and embolization of the left subclavian. We did a T-branch that's very useful for treating this chronic dissection, and we have some experience with that also. And this is probably the most interesting case of this series. It was a patient that came with impending rupture with this anomalous position of the aorta and implantation of the subclavian. It failed the attempt to endovascular position of the graft. There are two grafts at that point, and we can still see the leak. So we did left thoracotomy and a sternotomy, and what we can see is a graft from the ascending aorta to the descending aorta, a cerclage of the aorta just proximal to the leak, and in this case evolved very well. So this is this distribution in terms of aortic aneurysm, aortic dissection, diverticulum, total of 53 patients. Surgical mortality is still high. I think this is a very critical group of patients. This is the kind of arterial substitute that we have used. And these are our conclusions, that total endovascular solutions at the area of the aortic arch aneurysm represent the last frontier to be overcome and are not yet available on regular basis. We don't have this fancy grafts from Cook and from Gore for regular use. And the complexity of and the proximity of the ascending aorta, cardiac and valvular physiology, and concomitance with the cerebral extracranial circulation makes its management particularly challenging. And hybrid solutions merging open and endo operations still represent a less invasive and effective solution for many patients with aortic arch aneurysm, and mainly by derivation from the ascending aorta without extracorporeal circulation, or by bridge from the carotid artery and subclavian to allow endovascular coverage of the dilated or dissected aorta. Reasonable results can be offered on benefit of patients with this complex disease. Thank you.